We can start.
Just a minute. It's on the process.
No problem, no problem.
They have started alive.
Yeah, you can start now, sir.
Okay.
Okay, thank you. Good morning, all. Uh, at the outset, I would like to thank Srinivas Samavadam sir, Ghanshyam sir, so to allow me or to give me the opportunity in Higgs platform to come and present on the troubleshooting on a ventilator. Now, today's topic is very important, is because nowadays the ECMO, like the numbers are going high, and any person in critical care, so we are bound to encounter patients on ECMO. So initiation, winning, removal ECMO is all important, and troubleshooting is equally important. So one should have to have one first-hand information on the common problems encountered in day to day on a patient on ECMO and the management strategy. So to start with, most of the complications are benign to start. So they look simple. Many a times in a day-to-day life, when the nurse or the bedside doctor comes and reports to us, so they look benign, but we urge not to take any complication or any like alarm like less seriously, because all when I looking alarms can after some time they can go into devastating complications. Now, to address the troubleshooting or to address the problems, we have to have at least the basic understanding of the patients, the indication for which we have applied the ECMO, the stage which at which we are dealing, whether it's the initiation, during maintenance, or weaning, or even on the after removal also problems can happen. Then I have to have a first-hand information on the kind of machine used, the consumables used, and the patient's vitals. That is very important. Now, more than that, we have to have a bedside troubleshooting flow chart. So, may not be always the expert is available in the bedside. So, anyone working in the team, they have to have the flow chart and they should know what to do if this kind of problems happen and when to escalate that matrix to the next level or to the consultant level. Then comes the team training. Okay, that's of course it's very important because the weakest link in the team is likely to breach. That's why it's very important. And last and not least, basically, to understand patient safety is the first. Now, whatever happens, now it's we are not going to treat or we are not going to like save the machine or the consumable. We are going to save the patient. So the first priority should be make the patient safe. If possible, isolate from the machine. If possible, take care of the patient fast. Then try to shoot the trouble. If the patient is safe, then we get enough time to see. So in that way, the complications with a machine, in a patients can be like to start with, it can be patient related. Many times, if a compromised lung or compromised heart, so it carries a different dynamics, different physiology compared to a normal lung function or heart function. So we have to have a very good understanding of the patients and the patient related problems. Very well, they can create problems or create or generate alarms on a patient. Then comes there are two external things. One is the machine, and second is the consumable or the circuit. There are setup problems which can come because of the inherent problem due to the machine. So we'll go into the details, and some problems can come with the consumables, that the circuit, oxygenator, or the pump related. Then there are even problems can happen due to operator related also. So if the person on the bedside is not very well versed with the patient's management, then a few complications can come. So whenever we are trying to address, so the problems can come from either of the area, and there should be a systematic approach to that thing. So this is how in the also mentions. So mostly the complications can happen because of the oxygenation related issues, especially whenever we are putting VV ECMO for a hypoxic respiratory failure. So it may happen refractory hypoxemia despite a full ECMO, full ventilator. So that is one common issue. So it may be benign, it may be catastrophic. So depends upon. Then second is the oxygenator failure, which is obviously catastrophic. Second is something like the flow related issues or the pump related issues. The flow related issues can be like the flow insufficiency or the chattering. Then it can be it can cause recirculation, which is the exclusive problems of the VV ECMO. North South syndrome, which is again related to VA ECMO. Limb congestion and limb ischemia. Limb congestion is particularly in VV whenever we use a bigger size cannula, and ischemia is especially a problem of the VA. Thrombotic and hemolytic or the bleeding complications. So I will try to avoid this thing because so that is a different like setup management comes. Then I like to specifically address the catastrophes which can happen and how to prevent, and if at all it happens, how to address on the bedside, like sudden air in the circuit, accidental decirculation, sudden oxygenator or the pump failure, oxygenator failure. So these are the some of the catastrophic issues. If we want to run a safe ECMO, then the team, anyone working in the bedside, have to have a basic understanding and the management art related to this common problem. Now, there are so many other problems can happen, rare problems can happen. We'll not go into the details for the student understanding's sake. Now, this is the commonly encountered problems. So what should we do? First is again, I told you the patient safety. Make sure your patient is safe. Identify the problem. Then look for the cause behind it. Then plan of action. Then documentation. Now let's go into one case. I thought to make a case-based discussion. I'll start with the case. So this is a real case. 26-year male, viral pneumonia, something VV ECMO. 25 French cannula on in the femoral site, 18 French in the right internal jugular. So patient is on 100% on the ECMO with a full flow of 6 liter. Right now, saturations are 77. And on your ABG, we see the radial arterial blood gas showing 80% saturation and PO2 around 45. So this is not an uncommon scenario to encounter in a patients. So where oxygen related problem. Now this I'm trying to put some picture here. So you can see patients sitting around 4.5 liter flow, 100% ventilator. And in ABG, 49 is the PO2 and the saturations are 77. Now what to do in this kind of patients? So now, before going to the case, we'll try to understand what are the common problem. What also mentions, according to also, the most common problem in adult respiratory ECMO is oxygenation related, not oxygenator failure. This is oxygenation related. 18% cases or the trouble we encounter this. Second comes the circuit clot. Then comes cannula site bleeding problem. And in cardiac ECMO, the most common is the pump failure or the hypotension or persistent shock. These are the some of the problems encountered. Now we'll try to understand. In our case, because it's a respiratory ECMO, VV ECMO, and we are encountering a desaturation. So let's try. So there are two kinds of issues we told. One is the uh, either there is a patient-related issue. There is a strategy to approach the hypoxemia. So it's grossly divided. If there is a patient-related, that means the consumption is high. Though the cause can be anything like a new sepsis, hypotension, or a stress, or a shock. Anything or a patient struggle also can cause the saturation to go low because of the increased consumption. Tachycardia may be a cause. Then comes the uh, if there is any compromise in the oxygen delivery, we'll go into the details. Either it's a flow, decrease oxygen carrying capacity of the blood. That means either decrease in the hemoglobin or the oxygen binding capacity. Anything can cause oxygenated related problems that can come. Now, worsening native lung of the patients, that also may be an etiology. And suppose patients machine related problems and can come little bit related to the oxygenating capacity of the oxygenator. So same as the uh, alveolar equation or the, so it depends upon the ECMO flow multiplied by the hemoglobin into 0.013 into 100 minus saturations. So what are the factors which determine the oxygen carrying capacity? First is the flow, second is the hemoglobin, third is the pre-oxygenator saturation, then membrane efficiency. Again, there are so many factors in it. and the flow to cardiac output proportion. That is a very important factor, which we will go into the details. So first of all thing, so we need to check how is the flow, whether the flow is sufficient or not. Now, how to optimize or how to calculate the flow is sufficient. So there is a rule of thumb. Ideally, for an ECMO machine or the ECMO circuit to adequately oxygenate the blood, at least 70 to 75% of the cardiac output blood should enter into the ECMO oxygenator. Now, in any case, wherever there is an increased cardiac output, either fever, tachycardia, sepsis, or stress, whenever the cardiac output increases, that time the ECMO flow should be augmented as per the patient's requirement. So, not doing that can cause the augmentation, and that is most frequently encountered issue in ICU in patients on ECMO. So we start ECMO when there was heart rate is 80. Now we forgot to increase the ECMO flow. Now when the heart rate is at 160. Right now, imagine at 160, the cardiac output is augmented. It became double. So our ECMO flow should be adjusted for the augmented cardiac output. In fact, that is the most common during physiotherapy, during mobilization, during pain, fever. We have to adjust the ECMO flow. That is the first thing to address the desaturation. Now, once we have made sure the flow is adequate, next thing we have to see the oxygenator function. Now, there are so many ways to check the oxygenator function. One the most commonly used is we check the pre-membrane oxygenation or the PaO2 in the pre-membrane blood, second in the PO2 in the post membrane, and we calculate the percentage increase. So there are two numbers which we usually take into account to check the oxygenator efficiency or oxygenator function is the absolute PaO2 in the post membrane. So also says ideally, so it should be more than 250. So that is alarm. If it is less than 250, that's alarm. And the if it is below 180, that is the cutoff to change the oxygenator. But practically speaking, people wait till 150. Sometimes we wait 100 also. Suppose your patient is not desaturating, that again, this number it should be analyzed in the context of the patients. But again, we don't advise to wait till 100. As per the ELSO, if your post membrane PaO2 is coming below 180, that is an indication. So for easy understanding, that number should be there. Entire team should understand. Now, second thing is the percentage oxygenation from the pre to post. Ideally, there should be 300 percentage oxygenation. That means suppose your pre-membrane oxygen saturation is it is 100, then the post membrane or the PO2 if it is 100, then imagine then the post membrane should be 300. If it is 60, it must be at least more than 180. So that number should be so checked. So it is very important to check the oxygenator efficiency. So in terms of oxygenation, there are other parameters to check in terms of the pressure drop and other things. We'll see. So that is one entity to be checked. Second thing comes is the recirculation. Recirculation is a common problem while initiation or before we adjust the flow, adjust the cannula site and other things. So it's recirculation is a phenomenon where the oxygenated blood which returns into the internal jugular instead of entering into the right atrium, right ventricle, it passes into the IVC and it enters into your ECMO machine. Again, that means the oxygenated blood becomes ineffective instead of entering in the systemic circulation. It enters into the ECMO machine. That is a problem. So that is a very common problem, and there are ways to find. So that is the recirculation percentage. Like the color of the returned blood many times give a clue, but if you are not sure, then we can calculate the recirculation percentage. That is the uh, pre-membrane oxygen saturation minus SCVO2 divided by the post-membrane minus SCVO2 into 100. Again, if you are very like keen, you can calculate. Up to 20 to 30% of recirculation is acceptable in VV ECMO. Should not cause a problem unless the patient is desaturating. Now, sometimes it happens that suppose your IVC cannula instead of going in RA, if it enters into the IVC. So that goes into a total recirculation, and we have encountered this patient in this kind of scenario. It can cause sudden desaturation and patient can arrest. So while initiation, suppose your patient is going sudden desaturation, the rule of thumb is withdraw the right internal jugular cannula or do it with the ultrasound guided or the echo guided thing. That is one thing. Second thing is ECMO flow. Suppose we are running on a very high ECMO flow, even if the cannulae are at a distance more than 12 centimeter, then also it can cause recirculation. So sometimes adjusting the cannula or the flow, okay, may help. Patient related factors, whenever the patient is or there is a obstruction to the right side heart flow, that means if there is a pulmonary embolism or pulmonary hypertension, especially in the late week of ARDS, third and fourth week of ARDS, again this problem recurs. We have seen this thing. So that time it's because the flow usually goes into the path of the least resistance, so easily it can go into the IVC instead of the pulmonary circuit. So during third and fourth week of ARDS, suppose we are seeing recirculation, then it is a sign that patient is developing pulmonary hypertension. So this entity should be kept in mind before this thing. Now, as I told, we can accept up to 20 to 30%. So, but again, we need to address the recirculation. In the beginning, there are certain things we have to do: change the flow, adjust the flow, adjust the pump speed, cannula size, and all those things do matter. And in the later phase, the only way to address is you have to address the pulmonary pressures, maybe pulmonary vasodilators, maybe the answer. Now, depending upon the cannulation site, suppose we are going for a femorofemoral, then it causes highest amount of the recirculation compared to the femorojugular, and the absolute answer for it is to go for a double lumen cannula. But again, the cost is a factor that need to be considered. Here I have put two pictures of the femorofemoral. You can see. So the return and excess cannula. So it's the distance should be at least 8 centimeter. Suppose you are going to femorojugular, then the tip to tip distance should be 12 centimeters. Now how to measure? It should be measured in your X-ray. So and it should be addressed. Now I have put here a double lemon cannula or the Abelin cannula, what is available. You can see here the return blood can directly go into the RA and the excess there is no way to mix or no way to recirculation. But again, dual cannula requires some amount of skill to adjust, so that we need to balance. Now, again, I was telling the ECMO flow should carry at least more than 60 to 70% of the cardiac output. That we need to keep in mind. Now, what happens? Suppose we keep on increasing the flow. Now, there are studies. So, if we keep on increasing the flow, so in the range of 4 to 6 liter or sometimes up to 7 liter, the oxygenating capacity, so it can be augmented, but more than 6 liter, again the oxygenating capacity of the oxygenator comes down. This is the diagrammatic picture you can see here. So the uh, suppose the patient is having in the picture A, you can see this patient is having a 5 liter cardiac output. Here 3.5 liter is going into the ECMO and 1.5 is bypassing. That means near about 70% of the blood is going into the ECMO. So it's an ideal situation. Now, what happens if you can see in the B picture, if suddenly patient develops something tachycardia and his cardiac output now just doubled, it became 10 liter. Suppose we do not increase the ECMO flow and we keep at same 3.5 liter. So now the ECMO flow percentage come to 35%. Even if everything is fine, oxygenator, pump, everything is fine, then also this patient will be saturated. So this is to make you understand that whenever the patient has a high cardiac output, we need to augment the ECMO flow. Now next, suppose we augmented, we made sure the hemoglobin is fine, the flow is fine, still the patient is desaturating. There are data, so people have tried to prone uh, the recent data, the prone ECMO randomized trial, though it doesn't favor, according to this trial, there was no great difference between the proning versus non-proning on ECMO patients. The rationale they mention is You have tried proning, that didn't work. Right now, you put the patient on ECMO, and there is no point in again going and trying proning. But again, there are divided school of thought. But according to this JAMA paper, there is no great benefit. So this is the prone ECMO randomized trial. Now, there is a flow chart how to address the patients on desaturation. It may look little complicated. I have divided this thing. Okay, let's go part by part. Now, what is the first thing to do is check the patients. Let me try this thing. Yeah. So titrate the maximum flow. You can go up to 7 to 8 liter maximum, even if ideal 5 to 6 liters should be sufficient. Because at 7 to 8 liter, there are other complications can happen, like hemolysis can happen. We need to be very careful. Imagine at the maximum sweep case and maximum flow from the ECMO at 100% FiO2 and hemoglobin of 10, still the patient is desaturating. Then the flow chart says you check two things over here, either recirculation or check the membrane function, which just we discussed over here, because these are the two very commonly encountered problems here. Now, if the recirculation is the problem, we discussed what to do. If membrane is the problem, then the answer should be to change the membrane, or if membrane is fine, then we need to think to add. Again, not very commonly practiced, but there is a way out we can think. Now, suppose the oxygenator or the membrane function is fine. You check the efficacy of the membrane, still it is fine. Then what? Then check if more than 60% of blood is going into the membrane or not. And if the answer is yes, that means more than 60-70% of blood is going into the oxygenator or the machine. Then what? Still your patient is desaturating. Then the flow chart says there are certain patient-centric strategy, or make sure or make something so that the consumption will come down. So what are the things to do? We can consider some sedatives, something to decrease the cardiac output or the heart rate, especially. We can try dexmedetomidine. Sometimes even people have tried beta blockers. There are articles, even these are sometimes criticized also, but there are ways to out. Then other ways are to increase utilizing the native lung. But again, that depends. If your lungs has improved, then probably we can try that to find like proning or increase P certain ways. Uh, so if these things works, then it's well and good. If not happening, then what? That means either the flow insufficiency or patient related. Then the last option comes is you have to go for a dual membrane. Now, using a dual membrane is little cumbersome because you require in parallel to oxygenator, that will again will be used with the two different machines, because you require two different pump also. That is little cumbersome, but again, there are ways to find solution. Then comes the in the next in troubleshooting with the flow related issues. So mostly chattering is the common issue, complete loss of the flow. So that comes on the catastrophic problem. Chattering, so the most common etiology may be because of the decreased volume or the volume loss of the patients. So it is many a times it is visible. Now, what are the ways to get out of that thing? That is, first, decrease RPM transiently and increase the flow. Sometimes, many a times, a kinked cannula, okay, can help. Then you can administer some fluids depending upon the patient's condition. Then the one more thing which we encounter very commonly is check the cannula position. Many a times, if the cannula is below diaphragm, if the patient is struggling to breathe, then definitely the infradiaphragmatic part of IVC is more collapsible than the supradiaphragmatic. So simple positioning the tip of the cannula many a times can help this issue to be sorted out. Then again, if there is a kinking in the line, we have to check these things. So these are the some of the ways to find the flow related problems. Again, patient position sometimes do matter. Give fluid bolus. So RPM again transiently we can decrease and increase this thing. So we have to see, and many times the cannula, the excess cannula size matters. If the patient is This cardiac output is high and we have placed a smaller access cannula. So then this problem is frequent. So we have to see. Then one more problem is persistent shock. This is one more problem which is mostly encountered in a VA ECMO. So like persistent desaturation in VB, persistent shock in VA is a patient. So patient was in cardiogenic shock. We started VA. Now this patient is having shock and not improving. I like to discuss this thing. So many times VA ECMO, whenever we place a VA ECMO, so two things we do. We like decrease the preload and increase the upload, which is counter to the physiology of the heart. So that creates some increased pressure on in front of the aortic wall, which sometimes jeopardize or can decrease the aortic wall opening. And the LV is already weak. So I like to you can see the echo here. I projected here the LV. You can see it is hardly contracting. Most important is you can see the aortic wall. It's not at all opening. So the blood is completely stagnant here. So this is one trouble we can face in VA ECMO. Now there are some strategies to address here. Now what you can do, either you decrease flow, but again that may be sometimes counterproductive. Decreasing the VA ECMO sometimes can worsen shock. There are two ways. Either we can do LV venting here, or we can place on IABP so that the pressure in front of aorta, the aortic wall can decrease like momentarily. You can see here. This is the video after placing the. You can see here the aortic wall is sometimes it is opening, not very frequently. Yes, you can see here. So we need to decrease or adjust the flow and do something. Now this is one. Yes, now it is opening. If even if not very frequently, but we need to make sure if the shock is persisting in a VA ECMO, then there are certain things we need to address. Yeah. So now the fine. Now these are the common issues encountered in VA. Now coming to the thrombus and like the pump related problems. What are the problems? That three set of problems can happen. Thrombus can be found in the pump. Second is air can be detected or sudden stoppage of the flow, which will come under the devastating. So it may be because of the motor or the power supply or pump head getting disengaged. Many times, so there is a sensor in front of the pump, which is basically a Doppler flow related sensor. So it requires the jelly as our ultrasound probes require. Anything problem with the jelly, inadequate jelly, that can cause stoppage of the flow. So because of the not being detecting flow. So these are the common problems we encountered. Now, what is the solution? Solution is there are two ways. If there is no like air or thrombus, you can put on the hand crank and take on it. But if there is air or clot, then there is a different set of problems. Now let's see what happens if there is a air. Anything like any breeze or any open the ports in the pre-membrane side of the pump can cause sucking up the air. It will be detected in the oxygenator. Oxygenator can stop also sometimes. Do not use hand crank. Do not use the manual here. That will simply push the air into the patients. Now what we need to do is first you need to stop the machine, clamp it, take care of the patients. Okay, de-air, that is the most important thing. Okay, we're not going into the de-airing mechanism. Then second, suppose we detected clot, what next? Again same thing, do not use the hand crank. Again the clot, if unfortunately suddenly it enters, then your oxygenator, right now your pump is failed, that will block the oxygenator as well. So in these two circumstances we cannot use the hand crank, and we need to disengage the pump, and we need to remove the air or the clot. Then other two problems, suppose there is a power failure. Okay, obviously the answer is immediately to take on the manual pump, and you have to rotate this thing. Then sometimes technical problems, console and other things, we have the ready-made thing. So we advise there always should be 4 line clamps and a 50 ml syringe with the lever lock facility. Remember, students, you have to have these things along with your hand crank machine. Now, suppose many times the perfusionist they will forget to keep the clamp and the 50 ml, then you cannot struggle that thing. So you have to make sure that 4 line clamps, 150 ml syringe with the lever connections again, because all 50 ml cannot suck the air. It should have a lever lock facility, and a hand crank should always be there. Now, grossly, these are the answer for the major problems. Now, coming to other uh, though not like common, but many times these are all problems we encounter. What happens if there is a hemolysis or the urine color changed? So this it's most commonly happens in if you run a longer time ECMO, more than 2 to 3 weeks, that happens, or if you run in a very high flow ECMO, suppose like 4 5 liter or more than 5 liter, definitely that's going to cause hemolysis. We need to be cautious about here. There are ways to out. So either people try hemodilution, that's one thing. Second thing is decrease the flow if it is acceptable. That's one thing. So we have to see. Now, suppose it is because of the membrane thrombus or the pump head thrombus, then we have to change the pump head or the oxygenator depending upon the patient's tolerance. So, how to detect it? Your bilirubin can increase. Serum free hemoglobin is a standard test which is done. Normally, we consider the serum free hemoglobin level in patients. It's ideally it is it should be less than 100 milligram. That means it's 0.1 gram per deciliter. So if it is more than 100 milligram per deciliter, it is alarm. If it is more than 500, and if we are sure it is from the membrane, then it should be changed. Or if it is from the pump, then it should be changed immediately. So that's it. Now, quickly we'll go into some of the catastrophic circuit issues, which you need to be always be ready to address these things. First is breach in the circuits. So it depends upon which part of the circuit got breached. Pre-pump, post-pump, different set of problems can happen. We'll go into the next slide. Air in the circuit, similarly, whether it is a pre-membrane or post-membrane or pre-pump or the post-pump, that is again important. Now, why? The reason is the your last part of the de-airing or the SECP mechanism is the oxygenator. Suppose any air before oxygenator, still we are in safer zone. After oxygenator means there is no de-airing mechanism, straight the air can enter the patient. Then comes the loss of pump flow or accidental decannulation. So these are the common catastrophic issues. Now what we should do? Patient safety is first. Isolate the patient. As I told, 4 line clamps. Okay, so switch off the machine, put on clamps. That's what is the first thing to be done whenever patients develop these kind of patients. Clamp the excess and the return. Now the return cannula clamp should be as close as the patient. That means very near to the uh, uh, the neck port. That is very important, so that you can avoid as much as air which enter. Then comes, suppose air is in the pre-pump. Now what to do? So stop the pump, remove the air. Many times either by gravity or by aspiration, as I told in the 50 ml syringe, we can do this thing. Then check if entire air is removed. Normally, if it's still not, it's a devastating, but still we have some safety window because of the de-airing mechanism at the oxygenator level. Suppose it is at the post oxygenator, then what? Immediately stop and clamp as close as to patient. Again, same thing should be done. De-airing should be done, and exchange the air with the saline. Next, accident or the devastating complication is accidental decannulation. Again, it depends which cannula is. It's like it's came out or it is about to come. You are still lucky if you detected the cannula halfway, but again, it's going to be a mess if the cannula is already outside. Suppose the excess cannula is out, it will suck enough amount of air, which will definitely bypass the de-airing mechanism, and it can cause sudden pulmonary air embolism and death. That's one thing. Suppose the return cannula is decannulated, still it can cause a death, but not in seconds, but definitely in minutes. So it will cause devastating blood loss. If you are running ECMO at 4.5, then 1 minute is sufficient to like bleed the entire patient's blood volume. So either decannulation accidentally, either excess or return, both are devastating. So a safety checklist: daily cannula site, suture and the strength of the suture, the integrity of the skin, everything should be part of the monitoring. That is it is very, very important. Then comes uh, again, now what need to be done? Suppose it happened unfortunately, then what you need to do? If the cannula is completely removed, there is no other way. Switch off pump, apply pressure at least on the return side of the patient or the cannula. Or suppose it is in the excess site, obviously we have to stop and see the air. Now, question comes, if we see the cannula is partly removed, then what? Should we push in or should we not? So this is the line I have quoted from ELSO. Though if the patient's native lung is recovering, then you try to remove, do not push it. Suppose the patient is desaturating, try to push if you are confident so. Because many times a partially out cannula can enter into a false track that can cause a added problem. So we need to be extra careful about the accidental decannulation. So this is the thing. This is the last part I may talk. Now, what else we monitor? We monitor three pressures. One is the P1, P2, P3. P1 is the patient's to pump. Ideally, not routinely monitored basically, but there are pressure range because any drop in the P1 pressure can give you visible sake or chattering. That's the reason ideally it's not required to monitor, but again, texts mention. So it's better to monitor. So the pressure range in the first part, it is the negative part of the circuit. So we accept up to minus 100 mmHg. So any pressure below minus 100, that means we need to address that will cause visible shattering or the movement of the cannula that can cause hemolysis or the flow insufficiency. Second is the P2 is the pump to oxygenator. That is the most positive side. So that depends. The pressure depends 250 to 300. Sometimes it will range to 350 depending upon the flow and the oxygenator the time. So more than P1, then comes the so P2, P3. P3 is the pressure after dropping the pressure in the membrane. What is important is P2, P3 pressure and the delta pressure, that is the drop in the pressure across the membrane. That is most important. So in any unit, a delta pressure, a serial like this serial monitoring of the delta pressure is very, very important. So to begin with, the delta pressure of 15 to 20 drop is absolutely acceptable. Beyond 30, we need to be careful. If it goes to beyond 50, that's an indication to change the oxygenator. That's again very, very important. So again, these are the P1, P2, P3, and the delta P. Again, more than 50. So not in isolation, more than 50. If the delta pressure is more than 50, the oxygenator function is going on. If the patient is desaturating, we have to consider other parameters as well. So not a single parameter. If these numbers are showing the patient the oxygenator is function is deteriorating, then these are indication to change the oxygenator. Now, so we don't want to scare you telling that so many complications can happen. So if it's a the fortune is bad, then probably even the rarest complication can happen. But the best way is to monitor, to put to train the team, and the entire team should know what to do if these problems happen. And don't take any of the alarms as benign because all benign looking alarms can go into devastating complications. So the teamwork, training, communication, documentation is very important because something happened in the night, it may be alarming, and the duty resident didn't hand over, and we forgot to address that issue in that day, and it is bound to happen in the next time. So many a times documentation and addressing the issue is very, very important. So need to remain vigilant. So so that we can run a safe ECMO.
Uh, Thank you, Niranjan. I
Yeah.
know sometimes listening to these things can be a little scary, uh, but I think having simple checklists from shift to shift. For example, you're looking at the transmembrane pressures, where the pressures, you know, within the normal range. Are you looking at the oxygenator functioning? Is it within the normal range? Is the pre and post oxidation stable? So a few simple checklists. So in each shift, right, as everybody comes and goes, you just kind of checklist and tick it whether that's been checked or not will help you prevent a major complication. You can kind of take care of a very large number of complications. But in case you have, don't panic, right? And try and see if you can handle by yourself. If not, seek help immediately. That is what I think. Especially if there's new somebody who's not been there, suddenly he's on duty and something happens, then there is a tendency for people to panic. It can be. I mean, it's
Yes,
natural. It's,
yes,
it's
sir.
very overwhelming, isn't it? It is
Yes, sir.
natural for somebody to see so many machines, lines, tubes, and suddenly something is going, away from the normalcy. There is a tendency for people to kind of get a little panicky. But again, as I said, seek help, go in a systematic way, and I think you should be able to tide over many of these problems.
Yes, sir.
Thank you, Niranjan. Anything
Yes,
else that
sir.
you want to add?
Thank you. No, no, sir, that's all, sir. So now for students and audience. So like all ECMO practicing units, they all have one like monitoring chart. It may differ a little bit, but a daily monitoring chart, as Ghanshyam sir told, that is mandatory. We have to have for a VV separate setup parameter and a VA separate setup parameters. We have to monitor, and it should be on hourly basis. Now, more than one value, the trend is very important. So, like sir told, the delta pressure trend. Suppose there is an increasing trend over maybe 2 to 3 days, and we took it or we neglected it, then that is definitely it's going to cause trouble. So, many of these problems, whatever we told, it can be avoided by the checklist.
Thank you, Niranjan. Thank you very much. Uh, we'll see you again next week with a different topic. Till then, take care of yourselves. Thank you.
Thank you so much, sir. Thank you. Bye
Thank
bye.
you.